This is our first speaker, Dr. Rebecca Wu, and we are very appreciative that she's here with us. She spoke last year at our meeting, and we felt that it was such a powerful presentation that we wanted to have her come back to us. She is currently involved with the Peace for Moms program. Many of you are aware of this. It is an resource for physicians and patients in trying to address the crisis of maternal mental health in our state. Dr. Wu has a quite storied history, and I had to really get clarification of it. She's had a very interesting life. She was from Augusta, grew up in a military family. She did attend Georgia Tech for undergraduate, then did postgraduate studies at University of Georgia, completed a master's, and then did go to the Medical College of Georgia for her undergraduate medical education. She then went to Baylor for her residency in obstetrics and gynecology, so she is also an OBGYN. And then she went to overseas and worked in Germany, and then came back to the U.S., and after practicing OBGYN did elect to go back and complete a second residency in psychiatry that she completed at MCG. She currently is in Atlanta working for the Peace for Moms program. Many of you may be familiar with Toby Goldsmith, and that is also she is another contact for that program. It's my honor to introduce Dr. Rebecca Wu. Thank you.
Hi. Good morning. We can scoot back a little bit. Okay. All right. Well, my name is Rebecca Wu. I'm a perinatal and reproductive psychiatrist at Emory. I like to tell people that I'm a gynecologist because before I was a psychiatrist, I was an obstetrician. And now I focus on maternal mental health. I am supported, as Ruth said, by a grant from the Georgia Department of Public Health, which funds the Peace for Moms program. Peace for Moms stands for Perinatal Psychiatry, Education, Access, and Community Engagement. We're a psychiatry access service that provides consultation across the state of Georgia. Unlike many expressions of disclosure, I will not give you an unbiased view, and I will try to encourage you to use our services. Peace for Moms also recognizes that not every person who is pregnant or gives birth identifies as a mother or a woman, so I will attempt to use inclusive language as much as possible. I really like this quote from Great Expectations. I'll probably butcher it, but he references the long chain of iron or gold, thorns or flowers, and the first link that binds you. So whether your chain is one of gold or iron or thorns, take a second to reflect on that first link that started your chain, the link that brought you here. Whether it was a patient, a mentor, a life experience, that link that started you on the chain to caring for women throughout your life. Keep that link in mind while we talk about mental health care and maternal health over the next few minutes. I'll also disclose to you that I'm a little bit nervous because I know that some of the people here have been links in my own chain over the years. And I tend to make really terrible jokes when I'm nervous. And I have also included a number of really awful visual puns in my slides. And so I will do my best to ignore any groans or face palming that may occur. So, I want to take you on a roller coaster of emotion over these next few minutes. I want you to feel sadness. I want you to feel anger, frustration, and hopefully some optimism, and leave here feeling empowered. I want you to feel sad because women are dying. I want you to feel angry because this is happening right now in our country, in our state. I want you to feel frustrated because you've seen how hard it is for our patients to access the services they need. But I want to encourage optimism because there are things that we're doing. And I want you to feel empowered because there are things that you can do to optimize the care for your patients and to ease the burden on yourselves and on your practices. In practical terms, why should I be concerned? What can I do? And how can I do this? Most of us can agree that mental health has a significant impact on maternal health and health in general, but it can be difficult to integrate this philosophy into a busy obstetric setting. It's hard to think about postpartum depression or anybody's anxiety but your own when you're trying to manage a hemorrhage or an eclamptic seizure. Guidelines for screening for mental health conditions are sparse and vague, and even when we're asking about depression and making referrals to mental health services, it's hard to know how to respond to a positive screen or to get a patient to the care they need. So we'll look at some ways that maternal morbidity and mental health affect each other. We'll briefly discuss PMADs, the perinatal mood and anxiety disorders, and I'll introduce the role of psychiatry access programs like Peace for Moms, and talk to you about some of the programs that we're doing and how they may be implemented in your own practices. Let's start with a little bit of levity. Which TV show used the word pregnant first? Any guesses? So, if you said I Love Lucy, you are correct in thinking that Lucy was the first major character on one of the major networks to appear pregnant. And if you said that she was the first person to say pregnant on TV because I told you so, I apologize. I had said that before. I looked it up, and that's not correct. She was actually the second major character on TV to appear pregnant as part of a show, although she was the first on a major network. The series Mary Kay and Johnny, which aired in the 40s, was about another real-life couple. Mary Kay became pregnant. They worked into the storyline, and similarly to Lucy and Desi, their child was born on the day that the delivery show aired. So the real question, the real answer is a little bit controversial. Star Trek fans claim that the show was the first to use the word pregnant, 1967 episode, The Trouble with Tribbles. Actually, in 1962, the courtroom drama, The Defenders, featured an episode about abortion. The Virginian episode, The Golden Door, had a pregnant character in 1963, and Bewitched, Season 2, Episode 6, used the word pregnant in 1964. Which TV show featured the first Black TV mom? Yes! Thank you! Julia! The lovely Diane Carroll. She played the title role in the show. She was also a single mom and a working mom. The show itself had high ratings, but was actually pretty controversial because of the showrunner's refusal to address racial issues and the whitewashing that was presented in the show. Diane Carroll actually suffered some pretty significant mental health consequences due to the criticism that the show received, and she was hospitalized twice during the run of the show. Ironically, another show with an iconic TV mom, Good Times, was criticized for treating things like racial violence, gang violence, poverty, and discrimination rather glibly. So, now, which of these celebrity moms experienced life-threatening pregnancy complications? All of them. And you probably knew that as soon as you looked over at not just the answer, but the pictures themselves. These are pretty recognizable figures. And you'll also note that most of these women are women of color, which is consistent with the statistic that women of color, regardless of socioeconomic status, are more likely to experience pregnancy complications. And the fact that you know this almost automatically about these people. It tells you a little bit about how far we've come in the past 70 years. So pregnancy is not always quite so peachy, and we're starting to talk about that a little bit more. These women, in particular, have been outspoken about the toll that pregnancy and pregnancy complications have taken on their mental health, and the ways that perinatal mental health complications have impacted their lives and their careers. Perinatal mood and anxiety disorders, or PMADs, these are mental health conditions that kind of encompass mental health conditions that affect pregnancy or the postpartum. Pre-existing mental health conditions, conditions that are stable or relapse during pregnancy or the postpartum, or conditions that are caused by an event during pregnancy or delivery, or even something that just pops up during pregnancy that they've never experienced before and maybe never experience again. PMADs is a little bit less of a mouthful than perinatal mood and anxiety disorders, and it encompasses a broader array of mental health conditions than just saying postpartum depression. Most of us are familiar with the term postpartum depression and even postpartum psychosis. What you might not realize is that mental health conditions are actually the most common complication of pregnancy. About 20% of people are affected by a mental health condition. Anxiety and its many iterations, not just general anxiety or panic, but OCD and PTSD may affect pregnancy or postpartum. Postpartum depression is really best described as just peripartum depression because a lot of it starts during pregnancy, and actually some of it even before, not just postpartum. Dr. Patel spoke to you yesterday about substance abuse in pregnant women. Women with bipolar disorder are often diagnosed during the childbearing years. The 20s and 30s are prime time for a diagnosis of bipolar disorder. And in women that experience a severe acute maternal morbidity event, as many as 18% of those women will experience suicidal ideation afterwards. Pre-COVID, well, we might have seen about 1 in 7 with depression, and somewhere between 1 in 3 and 1 in 5 with an anxiety disorder. Post-COVID, everything's worse. About 1 in 5 experiencing depression, somewhere between 1 to 2 and 3 experiencing anxiety. And with the pandemic, the disparity in healthcare is widening. We really can't put a cost on mental health, but looking at lost wages and increased utilization of healthcare alone, Mental Health America estimated that each case of untreated PMAD costs about $32,000. And that adds up fast when you're looking at an entire country. 2017, 5 years ago, the cost of untreated PMADs was estimated to be in the billions of dollars. Well, let's put that into the context of general maternal morbidity and mortality. If you're here today, it's not news to you that Georgia is in a maternal health crisis, and that the United States has possibly the worst, but certainly one of the worst, maternal mortality rates in the developed world, far worse than countries that we would consider to be our peers from an economic, educational, or technologic standpoint. In 2010, Amnesty International ranked Georgia as 50th of the states for maternal mortality, with a rate that was on par with countries like Kuwait and Bulgaria. States were understandably alarmed at this information, and many of them, including Georgia, developed maternal mortality review committees. And I know Dr. Lindsay is speaking shortly, so I'll skim through the statistics and simply say that of the deaths that occurred due to pregnancy specifically, 85% of those were preventable, and Black women die somewhere between 2.5 to 3 times more than white women. Rural women fare fare far worse than their urban or suburban counterparts. If you are a rural white woman, you are 50% more likely to die of pregnancy-related complications than one of your urban counterparts. What's killing these women? Well, it's different depending on the time frame. If we're looking at time around delivery or immediately following, it's often cardiovascular, hypertensive crises, PE, things like that, and things that are largely influenced by obesity. Once we start to get a little bit farther out, things start to look different. When we look at things that are associated but not directly related to pregnancy, we start to see that mental health and substance use conditions are more influential. This is particularly true as we get farther into that first postpartum year. Suicides start to increase in about 6 to 9 months after delivery. And this makes sense. Your body is healing, but your mental health hasn't quite caught up. Worldwide, suicide is the leading cause of maternal death. And when we're looking at numbers from state to state, it can be hard to get the whole story. We're not very good at recognizing self-inflicted injury. Some states in previous years, although they're getting more consistent about it, have included suicide with accidental overdose or overall non-medical causes of death. So it's really hard to get the whole story just looking at the numbers. Mental health impacts pregnancy. Pregnancy affects mental health. This is a bidirectional relationship. In general, there's an increased risk of adverse outcome associated with patients who have a pre-existing mental illness. 40% of pregnant patients that were hospitalized with a mental health condition also had another chronic health condition, obesity, diabetes, asthma, substance use, one of these. Women with depression are more likely to develop gestational diabetes. Anxiety is associated with gestational hypertensive disease. Women with psychiatric disorders are more likely to experience a hemorrhage, preterm labor, preterm birth, or have a low birth weight infant. And while we seek to avoid doing harm, mental health may be collateral damage while we're trying to avert a bigger disaster. Patients with a near miss or an adverse pregnancy outcome, parents of NICU babies, those are much more likely to have a subsequent anxiety, PTSD, depression, or even experience suicidal thinking. And this may not resolve before the next pregnancy, and the cycle continues. Those of you who are familiar with Atlanta traffic are no stranger to roadblocks and detours. Sometimes it seems like there is no good option no matter which way you're trying to travel. Similarly, the barriers to obtaining mental health care seem to come from all directions. The patient, the provider, the system. Patients may not self-identify, we may not recognize. It may be hard to know how to get a patient into resources. There's still a lot of stigma associated with mental health, mental illness. Patients might feel a lot of shame, a lot of guilt. They might worry about being an outcast or being told that they're a bad mother. There's still a lot of worry about identifying. There's some good news. Mental health parity passed earlier this year in the state of Georgia, House Bill 1013, which is a little bit of a tongue-in-cheek joke because 1013 is the document for involuntary commitment. Somebody had a sense of humor. So that indicates that, or that mandates that mental health and substance use treatment needs to be reimbursed, covered and reimbursed at the same level that any other medical or surgical condition would be. But psychiatrists, only about 55% of psychiatrists accept Medicaid. And Georgia Medicaid does not cover psychotherapy over the age of 21 unless you go to one of the community service boards. So if you have a patient that would like to try psychotherapy before she tries medication, or if she wants psychotherapy or needs psychotherapy to go along with her pharmacologic treatment, she may have trouble finding a provider. A lot of counselors and therapists don't contract with insurance anyway or require people to submit for reimbursement themselves, so even patients that have private insurance may have a hard time finding an in-network provider. Georgia may be number one when it comes to football. However, we are dead last when it comes to mental health access. Mental Health America ranked us 50th again for mental health access in our state. We have approximately one mental health care provider for every 730 residents in our state. 65% of adults last year with any mental illness at all could not access care. The far left is a map of mental health care professional shortage. Ironically, if you overlay that with the obstetric provider shortage, it looks almost identical. So, what do we do? Well, the other thing to consider is that only about 20% of women with postpartum depression actually reported their symptoms to their healthcare provider. And this suggests that a large number of depressed patients are falling through the cracks, and that depression and anxiety might be a little bit different, look a little bit different in our pregnant or postpartum patients. Back in 2016, the U.S. Preventive Services Task Force recommended that all adults, including those who are pregnant and postpartum, be screened for depression. This was based on a review of several studies that suggested that even just screening for depression decreased the risk of depression at follow-up. FACOG has gotten a little bit more specific about the recommendations for screening for mental health. Initially, it was patients should be screened at some point in the peripartum time period. They've been more specific to say that at the comprehensive postpartum visit, everyone should be screened for postpartum depression and anxiety. But there's an alphabet soup of mental health screening tools, and it can seem a little bit overwhelming. However, some of the ones listed here, most of them actually can be done by the patient herself, can be done in less than 5 minutes, and can be screened by, or can be scored by clinic staff. The scores are generally on a continuum, so rather than a binary yes, no, does have, doesn't have, the score can actually guide the recommendations for follow-up and for treatment. And some of them, the Edinburgh postnatal depression scale can actually be utilized in pregnancy. The PASS is perinatal anxiety screening scale, and the City Birth Trauma Scale is specific to pregnancy and childbirth. So with so many barriers, it can seem like a dream to find a solution, an impossible dream. But there's some approaches that can level the playing field for patients and providers alike. Collaborative care options, either by direct consultation or embedded mental health care providers in clinic, actually bring a specialist into a broader setting. Non-prescriber specialists can be engaged in task-sharing options, and these are people like nurse navigators, home visitors, social workers, even peer support specialists that can be engaged to assist patients. Technology can be utilized, telehealth visits, interactive case conferences like Project Echo, and even hopefully at some point, artificial intelligence-driven psychotherapy may bring services to a broader number of patients. And mental health access programs like Peace for Moms. These are services where child and adolescent psychiatrists, addictionologists, specialty psychiatrists serve the greater community and support non-specialists in clinical services. So what's a psychiatry access program? Well, it may be a little bit easier to tell you what psychiatry access programs are not rather than what they are. So psychiatry access programs are not clinics, they're not crisis management services, and most of the time they don't interact with patients directly. They do provide clinical support in the form of medication recommendations, expert advice, up-to-date information on medications and treatments, so that a non-specialist clinician can initiate care in situ. Even if the patient will eventually go to a mental health provider, they can start their treatment right away rather than waiting to find someone who has availability, somebody who will see them and treat them while they're pregnant. And this allows for earlier intervention rather than delaying care. There are about 23 perinatal psychiatry access programs. This is the latest schematic from Maternal Mental Health Alliance, but not up to date because there have been several that have been founded even over the past, or that have been launched even over the past few months, including one in the VA system. Some of these are HRSA grant funded, some of them are state funded like ours. In addition to perinatal psychiatric services, there are programs at Grady that provide consultation on serious mental illness, so SMI advisor. And people at CHOA and AU are developing a child and adolescent psychiatry access program to support people who take care of kids and adolescents. So you might ask, if I'm not going to take the patient into the clinic, what's the point? Well, what access programs really strive to do is empower providers as well as birth workers to address their patients' mental health care needs on the spot, rather than deferring care. And whether you like it or not, research indicates that patients are coming in with mental health conditions. These statistics are looking at pre-COVID days, 2012 to 2014. There were an estimated annual 30 million mental health related physician office visits by adults over age 18. And only about 55% of those were with psychiatrists. The rest were with other types of providers, other types of doctors. ED visits for mental health and substance use, this is going back 2006 to 2014. That time frame saw mental health and substance abuse visits in the ER go up 44%. It's about 20 visits per 1,000 in the population. And again, these are pre-pandemic statistics. We know that that mental health has really been the song and verse of the pandemic. So how does this translate into practice? Now, this schematic was developed by Dr. Nancy Byatt. Dr. Byatt is the program director at MCPAP for Moms, which is the flagship perinatal psychiatry access program. MCPAP for Moms, Massachusetts Child and Adolescent Psychiatry Access Program was actually developed before MCPAP for Moms. MCPAP for Moms has been around for about 8 years, and now they also manage the Lifeline for Moms, which consults with all of the other perinatal psychiatry access programs. Dr. Byatt developed this to give just a visual view of what psychiatry access programs might do. As in care as usual, we might see a patient early on in her pregnancy, she's not doing so well, and we say, well, maybe you should go talk to somebody. Go look for someone in your insurance plan. Here's a list of providers. She's lucky enough to find someone, but she goes on a wait list. She gets worse, a few weeks later comes back and needs medication. Maybe we're not entirely comfortable starting her on something, and we say, well, let's get you in with a psychiatrist. There's a wait list, and again, she deteriorates. We're on a ticking clock when it comes to pregnancy, and this condition in this woman continues to deteriorate until the baby comes and potentially gets to the point where she tries to commit suicide and has to be hospitalized. It's a traumatic experience for her, it's a separation from the baby, and it sets up for some developmental and behavioral problems later on. If we can get to that patient early, if we know what to look for and what to do, and we have the support of someone to coach us through, we can make that intervention early on, and ideally get her into remission before the baby actually comes. What we're trying to do is catch patients at the primary care visit, at that initial visit, when smaller interventions like a support group or a small dose of an SSRI may be enough. These may have more effect early on. Knowing when an intervention is warranted, knowing what intervention might be helpful, and knowing how to implement those interventions, those are all things that Peace for Moms and perinatal psychiatry access programs can assist with. Our approach is three-pronged. We provide clinical support, but we also provide education and resource and referral. We're trying to bring together stakeholders at different levels within the birthing community, not just clinician prescribers, but therapists, birth support workers, lactation consultants, doulas, social workers, people to work together to support these women. For clinician providers, we can assist with medication recommendations, diagnostic clarification, helping develop a care plan. Occasionally, we'll do a face-to-face, one-time telehealth consultation with a patient. And we also have skills groups that we run as part of Peace for Moms operations. We network to connect with resources to support patients. We help find local providers for mental health care, but also charitable and state-funded organizations, or even some research-based programs that may be providing psychotherapy or mental health services as part of their work. And we recognize that mental health conditions don't exist in a vacuum. If you have trouble paying your bills or your rent, you're going to be anxious. And so we look at ways to address the social determinants of health. We work with residency programs, community partners, professional organizations across the state, not just obstetric, not just psychiatric, but family medicine, emergency medicine, pediatric groups, to try to increase awareness and recognition of mental health conditions. So we have also done work with community partners like the Refugee Women's Network, talking about postpartum depression. Our service launched in December 2020, and we have, at the latest count, done over 150 consults, and we just started our 7th skills group. These skills groups are not exactly group therapy. They're not exactly they're not exactly support groups. They're somewhere in between, and we try to describe them as classes. The U.S. Preventive Services Task Force had recognized 2 programs as preventative for postpartum depression. One of these being ROSES, Reach Out, Stay Strong, Essentials of Pregnancy, and the other one being Mothers and Babies. These groups can be done on a large scale. They can be implemented over telehealth. They can be done by non-clinical providers, so they can be facilitated by someone other than a therapist or a psychiatrist. In our case, both of these programs are held virtually. We offer them for free. And while they're not a substitute for therapy or for psychiatric management, these are really community classes that give patients a chance to connect with each other. And we've seen that isolation has been such a hardship during the pandemic. And seeing people be able to develop a community with others in their same space, in their same life stage, is just incredibly strengthening and therapeutic. Mothers and Babies was developed by researchers at Northwestern University. It's a cognitive behavioral therapy-based protocol that teaches stress management skills by looking at the interaction between thoughts, feelings, and behaviors. The protocol, as we follow it, meets virtually 1 hour a week for 9 weeks. And we also have 2 booster sessions where people get together 3 months and 6 months after their program to reinforce their skills, reconnect with their group mates, and just kind of talk about how their past few months have gone. Rose's is based in interpersonal therapy, and it really focuses on easing the transition into new parenthood, how relationships change, how to set up boundaries, how to ask for help, how to know who to ask for what you need, and how to ask for it. This is done in a 5-week series with one additional session postpartum. This program, we've just started our second run this past week, and mothers and babies, we're completing our 5th of series, our 5th group. Now, if you were to place a consult with Peace for Moms, actually, the initial steps can be done by somebody in your organization, a nurse, medical assistant, a resident, somebody in your practice, because we just really need demographics. That initial phone call goes to a community advisor, and we collect information. It's ideal to have a callback number that goes directly to you, like a backline or a cell phone number, and an email address so that we can send you any correspondence or summary that we need to. If you are calling about a specific patient, it's really better to have consent from that patient. Hey, is it okay if I call this person? And also ask them if it's okay, if we need to contact them. People get a little bit upset when they get a cold call from a psychiatrist. Trust me on this. Yeah. So when we have a consult, of course, we have a clinical question in mind. It's helpful to have their medication history if they've never been on something or if they've tried 16 different things, psychiatric history, and if they've done any of the scales like the Edinburgh or PHQ-9, what those scores might be, particularly pertinent to thoughts of self-harm. So once that information is gathered and that initial phone call is made, the community advisor will ask the caller when it would be convenient to return the consult call. If you're swamped, you're in surgery or deliveries for the next 3 hours, but somewhere around 2 o'clock sounds good, we'll time it just right. If somebody's in your office and you need an answer right then, we can usually get back to you within about 10 minutes, but almost always within 30. We'll go through the questions that we might have for you, and we'll send you a summary by email, as well as any resources that we might be able to connect you or your patient with. So our Peace for Moms team, Dr. Toby Goldsmith is my psychiatry counterpart. We have a resident, Dr. Philip Bowers, that is working with us this year. Our staff therapist is Dr. Whitney Adams. Erica Washington is our program coordinator. Jill Mast is our nurse. Catherine Black is our IT guru. And Michaela and Mikia, affectionately known as M&M, are our care coordinators. So they are the people that you will likely speak to initially when you make a phone call to us. Well, we will look forward to the future and look forward to working with you and serving with you. And I will take any questions that you have at this point.
Thank you for such a wonderful and timely presentation as we have now gotten our funding and our state in place. Any questions from the audience? Please feel free to rise to the microphone. Dr. Kaki.
Thank you so much. I'm Missy Kotke. I am at Emory in Atlanta, and I really appreciate this talk and personally have reached out to your group and found it to be very helpful, so thank you. I'm wondering if you could talk a little bit about, I think we're all excited about 1013, and just excited about what it could mean. I'm curious pragmatically what it means. And then a sub-question, if that money is there, and I'm thinking about the map that you have and how we have similar ones, of the real just lack of actual care providers, I was reminded by some of my lovely colleagues here this weekend about kind of how we've gone about our workforce and thinking about what can we do to help change, not immediately, but kind of the long view, and I was hoping you could talk about that.
Okay, so I guess so is your question about how we will get more people to practice mental health, or how we might get more services out to more people?
All the above.
Okay. So a lot of mental health interventions can be done by non-mental health providers, and this concept of task sharing. If you kind of think of mental health on a spectrum, it's not a one day I woke up depressed. It's this happened, and then this happened, and I didn't have anybody to talk to, and I really didn't know what to do, and now I'm really in a bind. So catching people earlier on, people that we know that are at risk, those who have experienced depression and anxiety before, patients that we know that are in unstable housing or financial situations, that may have experienced violence. The list of risks are numerous, but really kind of catching that early on. And that may be addressed by a peer support specialist. Actually, I believe Healthy Mothers, Healthy Babies is doing a peer support program. So having somebody who you can talk to that has been through it before. You may not be going through deep processing and cognitive behavioral therapy, but somebody to say, wow, you're not the only one that has experienced this. Nurse navigators that can check on patients. Hey, how you doing? Are you getting enough sleep? Do you need anything? Can we help you out? Those kind of interventions. So utilizing lower intensity interventions that can be implemented by non-specialists and engaged throughout the community is one. We'll start to offer in February a maternal mental health project ECHO. And one favor I would ask of you is when you do your evaluations, please indicate if you would be interested in participating in a maternal mental health project ECHO. For those of you who don't know what Project ECHO is, it's like a statewide case conference. So we have one for maternal health, but we're doing one in addition to mental health. We do about 5 to 10 minutes of a didactic session, and then we go through cases that are either brought in by us or ideally by participants in the group. It tends to work better if it's between about 30 and 40 participants. So we'll be shooting for that, and hopefully see some of you there in the next few months. So increasing other providers, other healthcare providers on the importance of looking at mental health issues. And telehealth options, telehealth sharing. I have patients that are getting a little bit irritable when I tell them they might have to come back in for an office visit over the next few months. Like, wait, you mean I have to come in? So, telehealth, and also hopefully developing some of the interactive programs. You may be familiar with Noom, which is the CBT-based nutrition diet coaching, but developing some programs like that, but for perinatal mental health. So,
thank you.
All right, long answer, sorry.
Okay, we have a virtual question. It's our first virtual question, and it's I believe it's Dr. Kassem who may be with us for a virtual format. And the question is, will you please share with us how a provider can access the Peace for Moms program?
Yes, absolutely. Our website link, or our website is on the bottom of the screen. It's peaceformomsga.org. There is a phone number on there think it is 470-977-3223. We don't have yet, and I emphasize yet, a way to submit consultations directly through the website. Right now, you do have to have someone call in to make that first contact, but hopefully at some point we'll be able to have consults that can be submitted virtually.
Thank you. All right, we'll go to this microphone here.
Thank you so much for your talk. I'm Caitlin Zabo. I'm at Piedmont, Atlanta. This is great because a lot of times we see a lot of patients and it's easy to feel very helpless when they come to you and are having all of these symptoms, and it's nice to have this resource. So I had a patient a couple of weeks ago who called me at like 4 in the morning and was postpartum and had tried to kill herself. And so I sent her to the ER and, oh, sorry, am I not loud enough? Sorry. I sent her to the emergency room and, and they went to a psychiatric facility instead, and she got turned away, actually. My understanding is maybe she wasn't sick enough. They were very full, had psychotic patients, and so they ended up going to our emergency room, and she was 1013'd at our hospital. So I think she was admitted to a med-surg unit, et cetera. It was the weekend at that point, so I was off of her care. But where do we send these people? Like, was that, I wanted her to be in a safe environment, but someone like that, what do we do?
You did all of the right things, and I would have told you the same thing. I would have told her the same thing. You need to be seen in the emergency room. I don't know what happened after that. When I hear stories like that, I'm usually a little bit flummoxed and a lot perturbed. There are some other resources that, not in a situation where a patient has actually made an attempt, but if she is in dire straits, that she can reach out to. There's a new maternal mental health hotline that can be reached 24/7 that's free. There's also a new suicide line, 988, where people can call and speak to a counselor. So Georgia Crisis Access Line should have somebody that can come out to see her and help assess whether or not she needs to be admitted and or 1013'd if that's the situation. Now, I won't promise that everything works perfectly. I have some anecdotes in mind where it has not, but you did the right thing, and that's what I would have done as well.
Just to segue off of that, do patients get prioritized to be admitted for inpatient psych care if they go through the emergency room rather than just presenting to a psychiatric hospital?
That gets into which psychiatric hospitals are receiving facilities. So you can't show up on the door of every psychiatric hospital and say, I need services. Depending on the hospital itself, there may be an intake process, or they may accept only through emergency service providers. So Georgia Regional, I believe, you don't have to be a physician, you don't have to be a psychiatrist, you don't have to be a physician to 1013 someone, and they can be taken to Georgia Regional, one of the Georgia Regional facilities, and evaluated, even if it's involuntary.
And then my follow-up to that too is there any talk, I haven't heard about this in a while, but the IV medication for postpartum depression, I think like brexanolone, I think is, if I remember correctly.
Yeah, I'm glad you brought that up. Brexanolone is a synthetic analog of allopregnanolone, and it's a neuroactive steroid. It got a lot of attention when it came out because it was the first drug, the only drug approved specifically for postpartum depression. It hasn't really taken off. In fact, I have a patient right now that is trying to get it, and she's going to have to go to Charleston because there's nobody in state that provides it. There are some big drawbacks. Number one, it costs about $37,000 for the medication alone. And number two, it has to be given over a 60-hour IV infusion with continuous monitoring, which means that your patient has to be admitted and there has to be a unit that's willing to take her and potentially a baby, but because the medicine has sedating properties, and the reason that we're monitoring them is because of potential syncope or sedation, that she can't be alone with the baby. And so there's some logistic issues from the patient, on the patient-child standpoint as well. So if you tell any new mother that she needs to go somewhere and sleep for 4 days straight, she's probably going to feel better. But I am encouraged by brexanolone, but also frustrated. The other thing is that its only FDA indication is for depression that starts in pregnancy or postpartum. And that gets into a lot of arguments about, is postpartum depression the same thing as depression that you happen to have while you're pregnant? So short summary is, it's there. We would like to be able to utilize it. We haven't really found a good way to do that.
All right. Thank you. We have one last question here.
Thank you so much for your talk. My name is Brittany Merritt. I practice in Richmond Hill, which is about 45 minutes south of Savannah. When starting an SSRI, often it feels kind of like a just pick something and hope it works. Is there a good resource that you have for non-psychiatric clinicians to pick the best medication for patients?
Yes. So we actually have a toolkit, a provider toolkit for depression. If I can bring up our website, I'll show you really quick where it is.
And then I guess when you're pulling it up, my second question is, when you have a patient who's been on an SSRI before and they've had success with it in the past, but now currently in the postpartum period, maybe they're not getting that same response, is there another tool for something like that?
I don't know if I can project this, so sorry, it's not projecting. So your first question about the SSRI and which to pick. So a lot of us like Zoloft because of the research associated with the safety profile. Zoloft is great, works for anxiety, works for depression. It's a good place to start. Zoloft has a lot of GI side effects. And so if you have a patient that is already a little really nauseous, Zoloft might be a hard one for her to try. So a good rule of thumb is whatever's worked before, or if she hasn't been on something but she has a close family member that has been on something and been successful, that's a good place to start. If it's Paxil, Paxil is the one that we kind of hesitate on, and then we kind of have to have one of those pros and cons discussions. Is this really the only thing that works for you, or would you like to try something else? If you've been on it and we know it works, is it worthwhile to go through trial and error while you're pregnant because we're doing multiple exposures? Where are you in the course of pregnancy? Is a cardiac defect even an issue? So when you're starting out, it's not just the right medicine, but it's the medicine that's right for her. So, and I'm sorry, your other question.
Just on a patient who has been on a medication in the past that's worked for them, but now is in that postpartum period and it's no longer working, or they're getting a partial response.
A lot of times it's a matter of dosing, because, and we'll find with many medications, not just the SSRIs, but throughout pregnancy, because their body weight changes, their metabolism is more active, their renal function, their renal clearance is greater, that we have to adjust dosing. And so if they've been on a 50 milligram dose of Zoloft and they've been happy for years and all of a sudden it's just not working, more than likely it's just that they're not getting enough. And so going up on the dose is stepwise. And the toolkit is really nice because it says, here are the doses to go up. Here's the time frame. Here's what you're looking for. I tend to go up a little bit faster, particularly my pregnant patients. You know, med school, we're always taught, well, you have to go 4 weeks and then check, and then you go 4 weeks and then you ask again. By then, they're like delivering the kids in college. But, you know, I tell patients, if this is going to be a good medicine for you, you should start to feel a little bit better in the first couple of weeks. You know, it's not going to be like a light switch, but, you know, you might wake up and think, wow, I can't remember the last time I had a meltdown. You know, things just seem a little bit easier. That really would have bothered me before, but, you know, and if that's the case, even if they're not where they should be, it's a good indication that things are working. And I tend to go up, depending on what the side effects they're experiencing are, about every week to 2 weeks in that first part, if they're really acute, because it kind of skips to the meat of things. Thank you.
And thank you very much for your talk. And maybe we can work on getting the toolkit to Kate so that we can all get that dispersed, because I do think that's a super relevant and helpful question.
Sure,
I really
absolutely.
enjoyed your talk.
Thank you. Good to see you all.
Okay, just